Two, one. Sir, we are live now. Now we can start the session.
Good evening, everyone. Welcome to the platform of Orthopedic Research and Education Foundation India. Today we have Dr. Swarnendu Samanta sir from Kolkata. Is teaching us about how to read X-ray for the practical examination of orthopedics. So over to you, sir.
Okay, thank you, respected John sir and my dear friend Janki. So I am going to share the thing. Today we are going to discuss the basic things for the PG students is that how to read the X-ray of the bone tumors. We are not going to discuss about the something like the CT scan or the MRI or the advanced nuclear medicine scan. Only we'll be discussing about the radiographs of the different bone tumors. You know that bone tumors can be like your primary or the secondary. Primary can be benign or malignant. Is it coming?
Yes, sir.
So when you see this sort of this thing, then you know that when you see the X-ray, we have to see 7 things in the X-ray. One is the where is the lesion, that is the bone and the part, and the age and size of the lesion, and what is the lesion doing to the bone, and what is the bone doing in response, and is the lesion making any matrix, and is the cortex eroded or any soft tissue shadow is there. So these 7 points must be there when we see the X-ray. So coming to the age, if we divide the bone tumor according to the age of, suppose the bar of 30, then if we come down to 30, then you see the picture on the left side, you will find that there is, if you go from the top side, there is fibrous dysplasia, Ewing's tumor, or the eosinophilic granuloma in the middle, or the simple bone cyst, or the chondromyxoid fibroma. Then if you come to the cortical side, you will find the non-ossifying fibroma, osteochondroma, or you can find the, if you come down to the epiphysis region, you will find the ABC, the osteosarcoma, and if you come down to the epiphysis, you will find the chondroblastoma and the infection. And if you go to more than 30, you will be finding in the middle, there is metastasis, there is myeloma, and the lymphoma in the middle. And if you come down to the metaphysis, you will find the myeloma, and then the enchondroma, and the chondrosarcoma. And if you come down to the epiphysis, you will find more than 30, the giant cell tumor. So I think age is a very, very important criteria of understanding the bone tumor. You can see on the left side, we are from 0 to 10, then 10 to 20, 20 to 40, then more than 40. And if you find the bone lesions which are well defined, the ill-defined and the sclerotic, then in the 0 to 10, you will find the eosinophilic granuloma or the simple bone cyst. Then you come down to the second category of 10 to 20, you will find the non-ossifying fibroma, osteoblastoma. This is the list is going long. I'm not going into detail of the list. Then if you go to the skeleton, the location, you will find from the skull to the calcaneus, there are different tumors which are specific to that region. Like if you go to the skull, you will find the eosinophilic granuloma, the mates of the myeloma. In the mandible, the adamantium is very common. The humerus, all are there. But the simple bone cyst we find there. Then the ribs. In the spine, we find the mets and the myeloma. In the pelvis, we find the osteosarcoma. So the list goes like this. And if we come in the transverse plane, if you go into the center, you will be finding the enchondroma. If you go to the eccentric region, you will find the giant cell tumor or chondromyxoid fibroma or the osteosarcoma. In the cortical region, you will find the osteoid osteoma. And the parosteal region, you will find the parosteal osteosarcoma. So I think the lesion which are osteolytic, this can be eccentric or this can be centrally located, and you can find that in the epiphyseal region, you will find the chondroblastoma, GCT infection, and always you have to exclude that you are not dealing something that with the infection. If you find a cyst or the cystic-like lesions of the bone, then you will find the solitary bone cyst or the aneurysmal bone cyst, the fibrous cortical defect, the fibrous dysplasia, the chondromyxoid, the calcification, chondromyxoid fibroma, and this giant cell tumor. These are the all expansile tumors which will look like the cyst. So now the second question comes, what is the lesion doing to the bone? It can be lytic or sclerotic. And when we see any lytic lesion, it can be geographic, it can be permeative, or it can be moth-eaten. So geographic means, if you see this picture, you will find that this is geographic, you can find that there is a well circle, the lesion is well marked by the sclerotic margin. But permeative means you cannot find the lesion, the margin of the lesion, which is because there is a long zone of transition. And when it is moth-eaten, basically the areas of destruction are ragged border. So these are the three types of your lytic lesion which you'll be finding, like geographic, permeative, or moth-eaten. And then the sclerotic is the other variety. So this is the classic picture, how we will understand that there is a narrow zone of transition. That means if you see this picture, you see there is a well circle, you can mark the lesion like this one. But if you go back to this picture, you cannot find a proper border. This is fuzzy, and you can see there is a periosteal reaction, and also there is a soft tissue shadow. So this is known as the wide zone of transition. So the Ludwig basically classified the margins. It can be like 1A, 1B, 1C, or 2 or 3. Or the lesion can be aggressive. The aggressive lesion will destroy the bone.
Oh, copy.
Am I audible, Janki?
Yes, sir.
Audible.
Now you
Yes,
are.
Sharan also.
Yeah,
So
I
aggressive
joined right at the beginning, but
Sir
carry
has
on.
also joined, sir. Yeah.
tendency. So this is the classic picture. If you remember that this is 1A, means there is geographic destruction. Like you see here, you can see the sclerotic margin. This is 1A. And if you go back to this picture, geographic destruction, you can see it is not like this picture like 1A. There is a fuzzy border. There is no sclerosis at the margin. And if you go back to 1C, you see there you cannot exactly delineate. There is ill-defined margin. Now 1A, this is the classic example of the 1A lesion. You see, this is the classic example of the 1A lesion. That's simple. This can be like simple cyst. It can be like osteochondroma. This is fibrous dysplasia. There is a sclerotic margin. This is 1A variety. Then if you go back to 1B, then you see there is no sclerotic margin. You see the tumor here. This is still well delineated, but the margin is not sclerotic. So you can have the differential like the diagnostic like the giant cell tumor, enchondroma, chondroblastoma, myeloma or metastasis, chondromyxoid fibroma, these sort of things. Then 1C, I already told you that you cannot basically delineate the margin. It is ill delineated margins. So you can have this list of, even sometimes you don't exclude the infection. It can be like the infection also. Then the second variety which comes, it is known as the moth-eaten. You see, it is like suppose something is eaten by the moth. You see here, the picture is complete. It's like the first diagnosis which in the moth-eaten probably will come like the multiple myeloma or the metastasis. Even you cannot exclude the infection. Eosinophilic granular osteosarcoma, this can all happen, but mostly it will fall into the category of myeloma or the metastasis. And this is the third variety, which is known as the permeative, is more aggressive. You see, if you go back to the primary picture, this is like something has been eaten by the moth. But if you go back to this picture, you will find that there is permeative sort of, you see, the small dot sort of thing. There is a lot of expansion in this cortex, and it is extending up to the soft tissue. So it is poorly demarcated from the normal, and there is elongated holes, slots in the cortex, which run parallel to the long axis of the bone. So it can be Ewing, it can be eosinophilic granuloma, infection, multiple myeloma, metastasis, lymphoma, or osteosarcoma. So these are the three varieties that you have to remember, that when you see the margin of the bone, that it can be sclerotic, it can be, you cannot find this is known as the geographic border, or else it can be moth-eaten, or else it can be like your permeative lesion. More you don't understand, you cannot delineate the margin of the lesion, it will be more aggressive, or it will be more malignant tumor. If you find the sclerotic border, that means the bone has limited the tumor inside it. So limited response. So what the bone has done to the tumor, it can be limited response, like there is be destruction. What is the reaction, like sclerosis, the remodeling. The rate of growth determines the bone response. Here you can see in this, there is a periosteal reaction. You see there is a periosteal reaction. So nature of the inciting process or the intensity, everything will dictate you to diagnose, and also the duration of that swelling. So now you see, this is the periosteal reaction, what has happened to it. So long-standing process, often non-aggressive. It can have a stress fracture, chronic infection of the osteoid osteoma. And if there is a speculated or laminated appearance, that means it is aggressive tumor. So this is the different varieties of what the periosteum has done to it. Like you see, the cortex has been destroyed. There is a persistent, the cortex is present, but it is a solid one. There is a buttress. Then there is a lobulated one cell, the single lamella, multiple lamella. Then you can find the Codman triangle. That I will come in next few slides. This is the Codman triangle, what you find. If you find this sort of picture like this is the periosteal reaction you find. This is the periosteal one. And this is the advancing tumor. That's why the periosteum has been elevated. And you see this triangle, this is known as the Codman triangle. This is the sunburst appearance, typical. Once you see this picture, you will never forget in your lifetime, which is known as the sunburst appearance. You see, this is like the something has been passed into the soft tissue. This is known as the sunburst appearance. Then the another question that we have to understand, what is the tumor matrix? What the tumor is producing? That means whether it is producing a osteoid matrix or a chondroid matrix. Or that means the cartilage matrix. So the most tumor matrix in the soft tissue in nature. So it is radiolucent, that is X-ray, that is lighting. And if you see the cartilage matrix, then you see the calcified rings, like the dots or the stippled ones. In the enchondroma also you can find this, and the ossific matrix that you find in osteosarcoma. So this picture I will tell all my junior colleagues, please remember this slide only, then you will remember the most of the things. If you see on the left, this is the osteoid matrix. You see, it is completely white one. And if you go to the second one, this is the chondroid matrix. You see, this is like the popcorn sort of appearance. And if you go to the topmost in the right picture here, this is the ground glass appearance. Okay, so this is the way how you understand, how you remember this. So always remember how to see the osteoid, how to see the chondroid matrix, and how to see the ground glass appearance. Okay. So now, as I have told you that how this matrix is produced, it can be like solid one, it can be the cloudy picture one, it can be like ivory one, or the stippled one, the flocculent one, or the ring and arc that is known as the popcorn one, like this sort of picture. Okay. So I have this I have told about the longitudinal orientation of the tumor. Now the tumor you can orient into the transverse plane where it is located. If you see on the left, it is the benign lesions, like it is well circumscribed, like this way, the lack of soft tissue mass, solid periosteal reaction, geographic, as I told you. But if the malignant lesion, there will be interrupted periosteal reaction. You will find the Codman's or the lamellated appearance, or else you will find the mortithal or the permeative appearance, and there will be soft tissue marks. And remember, there will be wide zone of transition. So now one by one, if you see, this sort of picture will be given in the exam, even in the OSCE. If you find this sort of picture, automatically your diagnosis will become like this is an osteochondroma or an exostosis. And you know that this is a very wide margin, so this is a sessile variety of that. So then you can come to the osteoid osteoma, which is very, very common. Sometimes you see in the different part of the bone, you will find the nidus, and in the diaphyseal region, you will find it. They will be double centroid bone scan. I'm not going to discuss on that, but in the X-ray, there will be classic picture. There is a sclerotic margin. You will find also the small knighted nidus. Then the osteoblastoma. There will be well demarcated margin over here, osteolytic and contenic flake of calcification. Less reactive bone than the osteoid osteoma. This is less reactive than the osteoid osteoma. Simple bone cyst always come in the OSCE or in the table. Always remember the proximal humerus is probably the most common area which we find, and also it is an expansile lesion where you will find, and this is the classic sign. This is known as the pollen leaf sign. Whenever you find this sort of expansile lesion in the juxtametaphyseal region, falling fragment, then the diagnosis will come right, the simple bone cyst. Then the aneurysm bones, you see, if we go back to this picture, and if you come back to this picture, there is a gross honeycomb lesion, which is completely different from the simple bone cyst. Often eccentrically placed and does not extend to the joint, unlike GCT. GCT will this will be close to the joint and warm to hot on bone scan. So this is the picture of the GCT. I have seen, I think all my junior colleagues, they have seen the GCT around the distal radius. You see, this is an expansile lesion, eccentrically located. It is close to the joint, and you can see the classic soap bubble appearance in this sort of picture. Sometimes it can break. There are different types. This is the classic picture of the fibrous cortical defect. The margin is well defined, and sometimes the cortex can be scalloped. This is non-ossifying fibroma. You see, this I have already told that you can see the margin, wide margin here, and this is the wide margin here. This is located here. Okay, you can see here in different parts. Fibrous dysplasia. This will come in the OSCE. This is known as the Shepard-Cook deformity. You know that because as I told you, the ground glass appearance, the whole femur has been completely built like a crooked appearance. This is the Shepard-Cook deformity of the whole femur, and this is an expansile lesion. You see, you cannot, once you see this picture, you will never forget it. So this sort of picture you will find circumscribed lesions. This is fibrous dysplasia. This is classic picture of enchondroma, and this is a scalloped erosion. Most you can find there is small flecks of calcification. Even in the phalanges, you can find this. In any part you can find it, but sometimes it's more common in your phalanges. Chondromyxoid fibroma, another one. Rounded or oval area sort of thing. You will find this eccentrically placed near it may cross the growth plate, and sharp outline. You can see the sharp scalloped margin on the thinning of the cortex. This is chondroblastoma. So you see, well-defined area, rarefaction is there. 50% show central calcification, and there is linear periosteal reaction. Once you see this picture, you will never forget in your lifetime. This is classic picture of multiple loose body. You see, it can happen mostly around the knee, but sometimes it can happen around the hip, also in the shoulder. This is chordoma. You see, large osteolytic lesion in the sacrum. Mostly it happens in the axial ones. May contain flecks of calcification, and there is marked destruction of the bone. Brown tumor, another thing you should not forget. This is a diffuse osteopenia with multiple osteolytic lesions dispersed throughout the skeleton. And also you have to investigate and you have to prove that you are dealing with a brown tumor. Even sometimes if you take the X-ray of both the hands, and if you see this sort of osteolytic lesion in your hand, immediately you should trigger that probably you are dealing with the brown tumor. Adamantium, the classic locations are the tibia and the mandible. This is the honeycomb appearance you can see in the tibia, cortical thinning with expansion. Hemangioma, in the vertical striations you will see, sometimes you will see in the vertebra, there is this sort of striations are there. Okay. Eosinophilic granuloma, there is motile lytic defect, usually no sclerotic rim. You can sometimes, if you do a skull X-ray, it may destroy the cortex. You will find this sort of lesion. And once the Ewing sarcoma, you have to remember that moth-eaten appearance and the lytic destruction is common. Often the cortex is perforated. And the classic picture of the Ewing sarcoma is the edge and the onion skin appearance, and because there is multiple layer of the osteum. And you may find Codman triangle here. Osteosarcoma, never forget this. This is a very common X-ray which is given at the exam. Always, I already have told the sunburst appearance, the Codman triangle, the classic location, and once you see this sort of expansile lesion in the distal femur around the knee, and this, when you see this sunburst appearance and this Codman triangle, immediately your diagnosis will be like osteosarcoma. Then chondrosarcoma, these have got some specific locations around the pelvis. You can find this, and also there will be cortical destruction and central calcification. Once you see this X-ray, once you go into the depth, once you follow the classic way of seeing the tumor, whether it is sclerotic or lytic, what is the margin, how it is, whether it is expansile, what is the age of the patient, and whether there is any calcification, whether how it is behaved, how the bone is reacting to that expansile lesion or the tumor, or whether there is a soft tissue shadow, probably you will not miss the diagnosis. Fibrosarcoma, which is very uncommon tumor, is not given in the exam. And the metastatic bone diseases can happen. Always remember the double organs like the lungs, the kidney, the adrenal, the thyroid. These are the common thing. And then the prostate, bladder, testes, breast. These are the common thing from where the metastatic tumor will come through. And if you see this femur, if there is a pathological fracture, and you see this sort of lesion, this is a lytic lesion, most common in male, the diagnosis will trigger through is the kidney one. So these are the classic picture of you see the mottled appearance, moth-eaten appearance throughout the skull and the pelvis, and it will look like this is the osteoblastic. So osteoblastic, you know that it's coming in the male from the prostate. Mixed pattern of destruction you can find even in this group. Lymphoma can happen sometimes. You can see the white vertebra, and the very mottled, loosened appearance also you can find there, and the Hodgkin disease also. This will create like this. Myeloma, this is the moth-eaten appearance. If you see you see this sort of X-ray, you will never forget the lesion. You see the multiple lesion in the skull, punched out lesion. These are the classic description of the punched out defect. It can be solitary, then it is plasmacytoma. The suspicion has to be there. So there are few mnemonics that I will be giving you that you remember, like the monoosteotic lesion. This is known as the Fock machines, like fibrous dysplasia, osteoid osteoma, giant cell tumor, metastatic disease, aneurysmal bone cyst, chondroblastoma. This mnemonic you have to remember for your exam. And if it is a polyosteotic, then this is like high fame, like hyperparathyroidism, infection, fibrous dysplasia, angiometastatic lesions, multiple myeloma or metastatic disease, or chondroma. If you are playing with the odds, anything can happen. So the shortlist your bone tumors into epiphysis, metaphysis, and diaphysis. If you remember like ECG, like epiphysis, C is your chondroblastoma or the clear cell sarcoma, and G is your GCT. If you come to the metaphysis, remember like sofa and chair, like S for SBC, osteosarcoma, fibrous dysplasia, ABC like aneurysmal bone cyst, or the chondroma or the chondrosarcoma. If you come to diaphysis, you remember like male officer, like multiple myeloma, adamantioma, leukemia, Ewing's, and the osteoid osteoma. So this is the small few mnemonics that we remember for your exam purpose. Then if you see the internal trabeculation, even if there is a simple mnemonic like change, like chondromyxoid fibroma, hemangioma, ABC, non-ossified fibroma, GCT, and desmoplastic fibroma. Then this is the classic picture of the ivory vertebra. So there is also mnemonic for this. This is known as the limb. Like lymphoma, infection, metastatic disease, and the Paget's disease, you will find this ivory vertebra. Then vertebra plana, you see this, probably sometimes you will find that this is a compression fracture. This is not only the trauma, it is the mnemonic for the vertebra plana is the eye melt. That means infection, metastasis or myeloma, or the eosinophilic granuloma, lymphoma, or the tuberculosis and trauma. So remember, eye melt is for the vertebra plana. So if you just shortlist your aggressive and non-aggressive, I think now we will be understanding that if you just see the margin of the lesion, if it is lytic or not, if you locate where is the lesion, if you see the age of the patient, you see the zone of transition in the aggressive is wide. In the non-aggressive, it is narrow. That means you can delineate it. So if you remember this slide, the aggressive and non-aggressive, you will be remember that the margin, the periosteal reaction, the presence of visible tumor matrix. You have to see the matrix. Matrix also tell you that immature matrix. Here the formation of the dense bone is there. It is non-aggressive. But in the aggressive group, there will be immature one. And the cortical breakthrough is present here in the aggressive group. It is not there in the non-aggressive group. So I think bone tumor radiology is not very complex. If you see, if you just can answer all the 7 questions, like where it has, which bone or which part of the bone has been affected, what is the age of the patient, what the tumor is doing to the bone, what the bone is doing to the tumor, what is the matrix, and what is the surrounding tissue is there, where there is calcification. If you answer these 7 questions, you can jump like a master. But if you just don't follow the principle of understanding the X-ray, probably you can stump through. So this is a very crisp sort of presentation which are basically needed for your exam purpose, because bone tumor as such is a very big topic, because all the investigation does. The X-ray is the first picture that we take, but reconfirm we do sometimes with the CT scan, we do the MRI, we investigate with the nuclear medicine, then we do the blood investigations and all this. So this is I am just giving you what the first information that you get from the history, and you take the X-ray. Once you take the X-ray, you just try to answer all these basic 7 questions. If you can answer it, all the 7 basic questions, probably you will narrow down to 1 or 2 or 3 maximum diagnosis. And remember, the first thing you should not miss, whether this is a benign lesion or a malignant lesion. Otherwise, you will not do justice to the patient. Thank you very much for your kind and patient hearing.
Thank you, Swarnendu. Very insightful lecture, and if there are any questions, please feel free to ask them.
So, if anyone have some doubt, you please ask, please.
Sir, anything to add on? Or anything to add on? Because I tried to make simple, because it is a very, very big topic.
So there's only one thing I noticed was the skull. I think one very common sort of tumor that people present with, which is not of any significance, but is like an osteoma. Okay, so just a small
think-
lesion.
Yeah, this internet is bit.
Is it
Yes,
mine
sir.
or? So osteoma of the skull or skull bones is something which is fairly common and which causes sort of worry among patients, but is nothing of any import. You usually don't do anything for it.
And just one thing to add, sir, one more thing, like some metabolic diseases also appears like hyperparathyroidism.
Yes,
You mentioned
metabolic
that.
disease, I have willingly I have
mentioned
not
that.
taken that, because you have to also exclude always the metabolic disease. because that is also a big part of that. You should
DD.
not forget that metabolic disease, because sometimes it can mimic with your tumor ones.
I thought you had mentioned hyperparathyroidism, brown tumor.
Hyperparathyroidism I mentioned, but
Yeah.
I have not mentioned
Other
any
metabolic
other part of
disease.
it, other part, because otherwise it will be complex one.
Yeah.
Because hyperparathyroidism they should not miss.
No questions?
Anything to add
So
on,
it-
John sir? Your from your side.
No,
So
I mentioned that, I think.
what the PG student should take home from this presentation.
I think that
Your just 4-5 master lines so that they can remember and go home.
no master lines. Just, I think what you mentioned was absolutely important, is that the first thing is to make a clear identification as to whether this is a benign lesion or not, or something that you need to check out and biopsy. So there's some lesions we still don't even biopsy today because we are sure it's nothing to worry about. Like say an osteochondroma, which is there for a long time and is not growing or is not suddenly growing rapidly. We know that we don't even do a biopsy. There are other lesions which you may think are sort of benign, but you're not sure, so you want to get a needle biopsy for. And the third one is the truly aggressive lesions, where you know that they need ideally specialized treatment, or with an onco surgeon or not. Okay, so those are the three things that you need to be very clear about, because you may need radical resections. You may need, depending on the type, the sort of various markers. Now today there are a whole lot of tumor markers which is difficult to keep track of for everybody. So I think those are the ones which really should be handled by the oncosurgeon. So I think
I think if they follow the 7 lines, the 7 questions, so age to the margin to the matrix and how the bone is reacting, what the tumor is doing to the bone as bone is doing to the tumor, and what is the soft tissue, and what is the matrix, and age, which is most important, and whether which part of the bone, that means the epiphysis, juxtaepiphyseal, metaphyseal, diaphyseal, probably they will come down to 1, 2, 3 sort of situation. They should not miss the major ones.
Yeah, I agree. So, I mean, there will always be lesions which are difficult to interpret. One of the classical ones is the parosteal osteosarcoma.
Osteosarcoma, yeah. Parosteal osteosarcoma.
You can sometimes, because they're so slowly growing, that you might mistake them for some other lesion.
But one blessing in disguise in parosteal osteosarcoma, these are not less aggressive than the classic ones.
Yeah. Then you have things like, again, non-tumorous conditions like myositis. Tuberculosis and infection is something which you
always.
keep in mind.
It's like whenever you send something for the biopsy, you have to send for the culture. And you send for the culture, you have to send for the HP section.
Yeah, and it's like one of the, especially in the young patient, you have to be aware that Ewing's tumor very often presents very similar to an infection, and you have to make sure you do a biopsy before you do anything more aggressive, because you can change the entire treatment protocol for that patient.
Okay.
So those are the few things which I think are important.
Okay, Janki.
I think you've covered.
I think everything went well today. And happy Doctor's Day, and my regards from Kolkata to one of my teacher, always my mentor, John sir.
Thank you very much.
And Janki is always there to organize these sort of meetings. And my hearty love from Kolkata to all my juniors, those who are listening to the program, because they were arranging this sort of program. And every time seeing John sir exactly on dot on time is really great.
Today I was trying to get through to the internet, but struggling for 5 minutes before I got through for some reason.
Today also I told Janki that how come John sir will be there, because today is Doctor's Day and he might be busy with something.
No, I was not busy. I was trying to log on and it wasn't coming through. Then finally I had to change to my phone internet to get through. The regular
Okay.
internet was not working. Okay, so bye. Thanks very much. And until
Thank you,
next
sir.
time, till we meet again, bye. Okay.
Thank you, sir. Happy Doctor's Day, sir.
Thank you. Thank you.
Happy Doctor's Day to everybody.
Thank
Okay,
you.
bye.
Thank you. Happy Doctor's
Sure.
Day.
Thanks.
Namaskar.
Thank you, sir. Thank you.
Bye.
Thank you.